I never.
Not very often. I think maybe once in my old practice where the person didn't want to go somewhere else, but
Generally,
it's not like no reason we couldn't. I mean, it's like many other medications we prescribe. As long as we're well educated on how to use it, no reason we can't. It's just that most of the people who have chronic kidney disease bad enough that they need it are actually in the category where they're already seeing nephrology anyway, so it often ends up coming from them.
And I'm going to try to look at that and see whether our patients are actually doing that. Like our patients with advanced chronic kidney disease and anemia, is a nephrologist involved? Are they getting, their EPO, that kind of stuff? So we'll have some data on that. So that's not my primary outcome. Again, my primary outcome detection. So screen your patients who are at risk and realize when they have it, recognize that you know what the problem is, so that we can improve our reporting. No. Metabolic bone disease, again, indicated for CKD 3 to 5, is when you start to get the complications. Patients with metabolic bone disease have worse outcomes, generally fractures, bone pains, those kind of things. Decrease in quality of life, that kind of stuff. Check calcium, phosphate, PTH, and vitamin D. This is all from Kadoki, these things. This recommendation came from that UniNet study I was talking about for PCPs, that they felt uncomfortable with PTHs over 70 or phosphates over 4.6. So I just wanted to throw that in there. That I did not see that in the Kadoki guidelines. I saw that as their own little PCP, primary care practice guidelines.
Getting vitamin D and phosphate binders.
Right. Attempt to keep the calcium PO4 product less than 55. I think this was also from that UniNet study. I think what the Kadoki said was just that the calcium phosphate product goes high and you want to keep it low. So yeah, you give the phospholows and phosphate binders, try to get the phosphorus low and give them vitamin D. So if the vitamin D is less than 30, replete with ergocalciferol monthly, and if it goes less than 10, you may treat weekly. Once you've done this, it says recheck the labs in 3 months. Once you've sort of got them on a stable dose, I think you can probably space out that checking. But if once you're initially starting it, you want to check again in 3 months, you can make a difference. Again, we'll be looking at, I think we're only looking at screening for metabolic bone disease. I don't think we're looking at any outcomes related to that. Whether they're getting ergocalciferol and all that. So this is when to refer to a specialist. I thought this was not this late in the lecture. When the PCP cannot formulate a plan, cannot complete the evaluation, or cannot offer the recommended treatment. Right now, it's probably a lot more people than it should be, but we're trying to improve that. So we're working on formulating the plan, like we said in the last slide. We're working on the evaluation last lecture, and the treatments this lecture. In general, all patients with CKD 4 to 5 should be referred. GFR less than 30, refer. That's from the Kadoki guidelines. This is from the Kadoki guidelines. Other things you might consider, these are just common sense things. This came from the UniNet. I just wanted to throw this in here too. This is not from Kadoki. But just sort of discomfort, persistent hematuria, you're not really sure why, maybe you want a urologist or a nephrologist involved, obviously. Proteinuria that's out of proportion to the eGFR, maybe there's something else going on, maybe you don't have the right diagnosis, maybe they need further workup. Again, you might want nephrology. Uncontrolled hypertension, they're like, you're not able to get it down, nephrologists can help you with that. Maybe they're actually indicated for something that you can't do. Any sort of metabolic abnormalities that you can't correct, or any rapid progression of disease. Again, if you're uncomfortable, you're not sure why they're going so fast, you haven't really gotten them back to that sort of 4 per year decline, maybe you want to know if there's something else going on, if there's something more you could be doing. Again, these top 2 are from Kadoki. These came from elsewhere. Just thinking about other things that might make you a little bit more worried. Something outside of the norm that's going on. So we'll go back to our goals and objectives. Can anyone tell us to develop a clinical action plan for CKD based upon its stage? What do we mean by that? That was one of our first slides where you said at stage 1, what are you doing?
Prevention, stage 1 and 2.
Preventing, trying to decrease the decline in GFR, coming up with a diagnosis, evaluating it, all that kind of stuff. What are we doing in stage 2? Estimating decline. When are they going to reach renal failure? Seeing whether your treatments are working. Are we slowing the decline? Are we giving them more time till they reach final renal failure? And stage 3, that's when you start to get the complications. When you're looking for anemia, metabolic bone disease, start thinking more and more seriously about cardio protection. Well, you could do that at stage 1 and 2. There's some thoughts that everybody with CKD should be getting cardio protection. And then 4, refer to nephrology. And sort of that's once you get below 30, let them sort of handle that. That's what I'd say. So Kadoki says at 4 on, refer to nephrology, they're going to be involved. 4, start planning for dialysis. So remember, all blood draws from one arm, that kind of stuff. Maybe think about referring for a AV fistula. To understand the management of diabetes, hypertension, proteinuria, and progression of disease, we talked about your diabetic goals, your hypertension goals, how proteinuria relates, especially with RAS and hypertension, RAS blockade and hypertension, and how managing these can decrease the progression of chronic kidney disease. CVD risk, you should consider all chronic kidney disease patients in the highest risk group, is what the Kadoki guidelines say. And when to refer to nephrology, again, we had those extra caveats, things that might make you more concerned, but it's when you don't feel comfortable, you can't come up with a plan, you don't know what's going on. I forget what the other thing was. And then also stage 4 or 5, less than 30 GFR. That's it. Do we have any questions? Don't stop it yet. Yes?
Is there any way, or was it in the plan of your study, to put printed copies of the guidelines anywhere? Or are we supposed to just memorize them?
This will be online. I did not write that into the protocol. If I'm going to do that, I probably have to do an addendum to the IRB application. But I have been thinking of that, of having a little flyer that we have in the precepting rooms.
Because I think, your goal is to educate all of us.
Right.
And I guess it might be a stretch, but that could just be part of your ongoing education.
Right. And part of it is I'm not looking at individual performance, I'm not looking at individual doing tests, I'm pulling all the data and I'm looking at our group improvement. So part of it includes the lecture today, part of it includes everybody seeing the lecture, part of it also includes you by word of mouth, spreading what you learned today to other people on rounds, to your preceptors when you're precepting, preceptors to residents who come to you in precept. I hope that this disseminates a little bit more, group knowledge goes up, and then that also affects the outcomes.
So the slides
Because my IRB reviewer is very anal.
That's on tape, Abe.
That's on tape?
Yeah, that's on tape.
Yes, that's the reason why.
They're all like that. I think he got one that was particularly so.
Yeah.
But I mean, if one of us did that and put it up for everybody else to see, would that still have to go in your IRB? I mean, I'm just thinking that would help me. I know I can't
Increase
memorize
awareness.
the stages, even though you just.
I don't know. Should I probably ask them? I don't.
You can't exert every bit of control over your environment. So if something like that were to happen,
That's true.
it's not,
I mean,
it's not.